So it's an honor to introduce Dr. Douglas Brockmeyer. Anyone in Chiari, pediatric neurosurgery in Chiari knows Dr. Brockmeyer. Synonymous with Chiari, complex Chiari's. My favorite book is his book on pediatric Chiari malformations. So we have got, it's an honor to have Dr. Brockmeyer to give us a lecture on complex Chiari. Thank you, Dr. Brockmeyer.
Great, fantastic. Thanks for the introduction, Dr. Narenthiran. I want to thank you for your invitation in general to speak on this topic. I'm going to add a little bit of controversy here. I know this conference has been going on for a couple of hours, and so I want to share some new thoughts and some new concepts. Plus, I want to share some preliminary results from a large registry that we've created in North America, and then some work that we've done locally at our hospital. So I just retired from pediatric neurosurgery after 33 years, and I'm half-time on the adult side. And what I'm going to try to do in this talk is just distill the information that I've gathered over that period of time and share it with you. So there we go. So first, I want to acknowledge my mentors. Ron Applebaum was at the University of Utah. He was very influential, incredible thinker, and incredible speaker, or incredible surgeon, I mean. And the second person is Dr. Menezes, and I think everybody in this webinar owes a debt to Dr. Menezes and his pioneering efforts back in the 80s and 90s, looking at this problem and tackling the problems of the craniocervical junction. So we're going to move to try to reimagine Chiari malformation. And this gentleman has been shown several times already today. We all know who he is. Hans Chiari, 1891, published his original paper. And then in 1896, described the Chiari 4. And then Julius Arnold got in the act in 1907 when his students recommended calling it the Arnold-Chiari malformation, which is a term that's rarely used. So at this stage, there's a trend towards subclassifications of the Chiari malformation. And obviously everybody's familiar with the classic Chiari 1. There's a Chiari 0, a Chiari 0.5, a 1.5. We're part of the issue where we published our paper in 2012 about complex Chiari, describing it's a Chiari of 1.5 with the obex down and the clival cervical angle less than 125. And I think Hans Chiari would look at this. If you were dropped in from another planet at this point and you really stepped back and you tried to look at this, you'd probably conclude that this is really crazy. You know, that what is this subclassification scheme really adding to our understanding? And does it provide utility? Does it provide a coherent paradigm for further learning? Does it enhance our ability to do research or enhance education? And most of all, does it really improve patient care, of which subclassification a patient lies in? Or does this classification represent something that's archaic, it's cumbersome, it's hard for lay public to understand? If you were a medical student and took a step back and tried to understand the difference between a Chiari 0.5 and 1.5 or whatever, would you really be able to understand that? And in my mind, is it generally obsolete? So this is brought to light with this example. So here's a patient, there's two patients who come in. On the left-hand side, I think everybody would agree, probably a Chiari 1. On the right-hand side, sort of a classic Chiari 1.5 with a low obex down here, very, very tight at the foramen magnum. And you look at this, which patient was symptomatic and underwent surgical decompression? And I don't know what everybody would say. We'd probably have a 50-50 split. I'd probably look at the one on the right and say, wow, that patient needs surgery. But that patient came in completely asymptomatic, and the patient on the left underwent surgery. So how do we make sense of this? Are we at risk of classification and measurement fatigue. And maybe we should be placing less focus on eponyms and classifications and more effort on developing a useful pathophysiologically driven nomenclature. So this is where some of the controversial part kicks in, So I got together with my colleagues, Dave Limbrick, who spoke earlier, Cormac Marr, Jerry Grant, all distinguished surgeons and thinkers in the Chiari space. And we published this article in this last year about primary rhomboencephalopathy that I'd like to share with you in this audience because I think it's important to understand. So the rhomboencephalon obviously is defined as the hindbrain, and it consists of the pons, the cerebellum, the medulla, and the intervening structures, the fourth ventricle. And if you have a disorder of the rhomboencephalon, which is what we're talking about here, by our logical way of thinking, you should call it a rhomboencephalopathy. And I think that makes perfect sense. We defined primary rhomboencephalopathies as the classic Chiari findings, the congenital Chiari, including all of the subclassifications that I just mentioned, and secondary rhomboencephalopathies, including all the other causes of tonsillar ectopia, including spina bifida, spontaneous intracranial hypotension, the IIH, craniosynostosis, which we just talked about, and Chiari 3 and Chiari 4. So two separate things that should be thought about separately because they have different pathophysiologies. So there are three fundamental mechanisms underlying primary rhomboencephalopathy, and it's three and only three reasons to perform surgery. One is a hydrodynamic problem, which we're going to talk about here in a second. The second one is neural compression, and the third one is biomechanical issues. And each one of these pathophysiologies has a cause or a driver. It may or may not have a genetic cause. It has certain signs and symptoms, surgical indication, and goals of treatment. We're going to go over these. As far as complex Chiari goes, as people know, with complex craniocervical kyphosis and severe constriction, all three of these pathophysiological mechanisms can coexist in the same patient. But having said that, most patients have one particular cause and driver that's driving what's going on with them. So for hydrodynamic mechanism, the cause is exaggerated pulsatility and pathological CSF flow in the cervicomedullary region, and you can have microstructural channel abnormalities either in the brainstem or the cerebellum. It doesn't have a genetic cause, but the symptoms that we all know are Valsalva-induced headache symptoms that we see over and over and over again, and syringomyelia is a hydrodynamic problem. The indications, again, are a syrinx or Valsalva-induced symptoms, and the goal of surgery is to restore normal CSF flow. Neural compression is just plain and simple crowding and bony compression and tissue distortion, primarily of the brainstem. It's possible that chromodomain genes may be responsible for some of this in young children. What are the signs and symptoms? So we all see patients, younger than 4 typically, with oropharyngeal apraxia, and they have swallowing difficulty, sleep apnea, motor delays, speech delay, which we haven't talked too much about in this conference. And that's a brainstem compression symptom. Or an adult patient comes in with a bulbar myelopathy and no Valsalva type symptoms, and that's just pure brainstem compression. And so the indications include oropharyngeal apraxia or a sensory or motor disturbance. And the treatment goal here is fairly straightforward. It's just decompressing the neural structures to provide more space. The biomechanical mechanism is more complex. It involves the cause, obviously, is craniocervical dysmorphology, perhaps ligamentous dysfunction. We're going to talk about Hox genes as a possible cause of that. And we had a paper published about a HOXC4 genetic mutation as a predisposition. The imaging findings are craniocervical kyphosis with or without basilar invagination, pain syndromes, headache and neck pain, or bulbar myelopathy. Indications include severe craniocervical kyphosis with brainstem compression. It can also occur with iatrogenic craniocervical instability, patients who've undergone multiple Chiari decompression procedures. Some patients have come to me with 2 or 3 previous surgeries and iatrogenic instability, or whether the patient has hypermobile EDS. And the goal with this patient population is to stabilize the craniocervical junction or decompress. So I'll just briefly mention this. We published a paper a couple of years ago with a couple of family trees. We had 2 sisters present to us, both with HOXC4 mutations in severe craniocervical kyphosis and syringomyelia, which needed decompression, fusion, and odontoid reductions, and another large family that was tracked through with HOXC4 mutations. So these these patients are fairly rare, but they're out there, and it's something to be aware of as a possible cause for this severe syndrome of craniocervical kyphosis and craniocervical dysmorphology. So I typically am not a big fan of treatment algorithms, but in this setting, I think it's relatively helpful to break this down. So the biomechanical group, there's a toolbox that you have available for you, and that includes the suboccipital decompression with or without duroplasty, and some sort of cerebellar tonsillar reduction, if you choose to do that, whether it's a coagulation or a resection. Occipital cervical fusion with or without odontoid reduction, and we're going to talk about that here in a few minutes. And then also ventral brainstem decompression or odontoid resection is part of the toolbox as well. For hydrodynamic patients, if you have a syrinx, obviously most people are going to do decompression and a duroplasty with or without manipulation of the tonsils. If it resolves, then you're going to follow the patient. If it doesn't resolve, if the syrinx doesn't go away over time on the serial imaging, in my experience, it's probably 5 to 10% of the patients, even despite a reasonably thorough, perhaps aggressive decompression. I think a lot of people on the second go around, and we're going to talk about reoperation, are going toward 4th ventricular stents from the 4th ventricle to cervical subarachnoid space. And I think that's been very effective in a lot of patients. And if that doesn't work, then you're thinking about the biomechanical pathway. For patients with the Valsalva-induced symptoms, it's very, very similar algorithm. And then with the neural compression, basically the idea is just to decompress the area and create more space. So what bony metrics do we use to determine abnormal biomechanics? And I'm not going to talk so much about instability in pediatric Chiari because that's actually quite uncommon. But we all know about the PBC2 measurement, the perpendicular distance between the basion and the posterior inferior aspect of C2. It was dichotomized greater or less than 9 millimeters. The pro of that measurement is that it's very easy to measure, and most everybody's familiar with it. The problem with the measurement is that's an indirect measurement of what's going on at the craniocervical junction. And really the odontoid and the retroflexed odontoid is just along for the ride. What's really driving that is the position of the occipital condyle and its relationship to C1. And that relationship and that growth is all genetically driven during embryogenesis and early childhood. Or whether you should measure the bony PBC2 or soft tissue. And the problem is it's not very sensitive or specific when it's been looked at in large patient series. The clival cervical angle of less than 125, we described that back in 2012. It's easy to measure. It directly assesses the relationship. The problem is it's not very sensitive. And if you have a clival cervical angle less than 125, it doesn't necessarily mean you have instability or abnormal craniocervical motion and you need surgery. However, if it's greater than 125, the chance of needing any type of craniocervical fixation is very, very low. A more direct measurement is one that we developed at the University of Utah. This condylar C2 SVA looks at the relationship of the midpoint of the occipital condyle and the relationship of the bottom of C2, and how that kyphotic relationship is at the area where the load is being transmitted through the skull into the upper cervical spine. It's a direct measurement. It is sensitive and specific. And I'll refer you to this paper here, this multi-center validation of that measurement using the Park-Reeves database. Problem is that it's a little more difficult to measure, and I'm not going to go into the details of that, but it's a worthwhile concept to be aware of. And again, basilar invagination is easy to measure, but there's very few studies really looking at the sensitivity and specificity of what that actually means. So ultimately, we don't understand much about how the craniocervical bony morphology can drive symptoms or cause progressive instability. So here's a patient who came to me with severe craniocervical kyphosis on the left-hand side, retroflexed odontoid. When you look directly at the occiput C1 joint, and I'm not talking about C1, C2 that Dr. Goel has talked about over the years, but this relationship here, so here it is on the MRI, here it is on the CT, and what does this mean? Do the capsular ligaments and occiput C1, are they intact? Are they not? If you do a posterior decompression, are you going to unmask instability? And these are questions that we just don't understand at this point. So what about the ligaments? We talked about hypermobile EDS. It's fairly common in adults, especially young adult females. It's uncommon in children less than 14 years of age. It's very poorly studied in the pediatric age group. I prefer not to use the term instability because it implies that cranial fixation, occipital-cervical stabilization is necessary then. I like to call it abnormal craniocervical motion, whether it's an occiput C1 or C1, C2. We're going to talk about that in a second. Again, we talked about iatrogenic craniocervical pain syndromes. That can be ligamentous in origin. Patients come in with severe de novo craniocervical kyphosis. They have a couple of surgeries for a variety of reasons. Those patients can come in extremely disabled with lots of head and neck pain. My preferred treatment for those patients is to go directly with a collar trial, a hard cervical collar. Sometimes the improvement can be dramatic and very durable in the collar. And you have a very, very careful conversation with the parents or the patient about whether that craniocervical fusion is necessary. Dynamic CT is something I've been doing a lot in my adult practice these days, and also with older teenage patients. Flexion and extension and rotation CTs. If you have greater than 41 degrees, this is all well published in the literature, greater than 41 degrees rotation at C1, C2, or 80% loss of facet overlap at C1, C2, it's an indication of potential instability in patients with hypermobile EDS, and patients can benefit from surgery. You really want to do the fusions only as a last resort. It's a very, very big decision for patients, and you want to be very careful with this. However, having said that, the results are frequently life-changing and dramatic for the patients. I'm going to shift gears here for a couple of minutes, and I want to share with you preliminary analysis of a registry that we've been running in North America called the Chiari Surgical Success Score. And it's the first multi-center prospective patient-reported outcome-driven study regarding Chiari malformation. And the primary aim of the study is to determine the probability that certain clinical or radiographic variables will predict a favorable response to surgery. And it's defined by two simple outcome questions. The first is the success of the surgery based on a 5-point Likert score, and you have to have a 4 or a 5 to define success. Plus, you need to have a 4 or a 5 on a question whether the patient or the parents would recommend or would agree to surgery again. So that's our primary outcome of this registry. The secondary outcomes is looking at the pre and post-operative changes in the patient-reported outcome scores. We use PROMIS 29 for adults and PROMIS 25 in kids. And we use the Migraine Disability Assessment Score, the MIDAS scores, to look at the headache burden for these patients. So these are the centers that have been involved. There's, on the left-hand side, the table shows the pediatric enrollment, and you can see there's a number of centers, approximately a dozen centers across the country, and actually including one in Australia. Over 1,200 patients screened and 217 pediatric patients enrolled. We're awaiting our final numbers of the patients being followed for 12 months. The enrollment, the adult side has been slower, and you can see that on the right-hand image, 771 screened, 195 enrolled, and 51 with a 12-month outcome. So here's the good news, and this is what I wanted to share this with everybody. Again, this is preliminary data, but I think this is very powerful. That these are the pediatric patients. This is as of July of 2025. 92 pediatric have completed their 12-month follow-up. 81% improved or complete improvement, so that's a 4 or 5 on the Likert scale. 83% of the parents agreed that they would undergo the surgical procedure again, and it has to have, for a surgical success, you have to have a 4 or 5 for both of those outcome measures. So it's a high degree for this. That's a very stringent definition of success, but it's a very, very high rate of success in this patient population. What was really interesting are the secondary measures, and you can see that the MIDAS scores improving to a significant fashion. Headaches, physical mobility, anxiety, fatigue, pain interference, and overall pain on the PROMIS scores. This is 1 year patient-reported or parent-reported outcome results. So this is very, very powerful, I think. And so we're comparing surgery versus non-surgery, but I think this is the first study to really show this in more lifestyle or symptom burden outcome measures. So with the adults, we have less patients who've completed their 12-month follow-up. So this is very preliminary, and it's the same story: high degree of surgical success and high degrees of changes in the preoperative versus postoperative symptom burden measured by the PROMIS scores and the MIDAS scores. So we have to complete 300 patients in order to build a robust surgical success score, 300 on the pediatric side, 300 on the adult side. There'll be 2 separate journal publications when they come out. So this is an interesting project that we completed at University of Utah. And over the years, I've been really obsessed with avoiding reoperation in patients. And we all know Dr. Jallo and others have talked about reoperation rates with bone-only decompression and whatnot. And so I've taken this to heart, and I've looked at my own experience over time, and we looked at this with our fellow from 2 years ago, Dr. Aaron Yango Khan. So what we did is that we looked at 12 years of data from our institution, 1,400 craniocervical procedures, with a preliminary EMR review that cut us down to 451, and we did a post-EMR retraction. We were left with 272 patients, first-time Chiari patients, treated at our institution over 12 years. So that was our patient population. And we used this statistical technique that I wasn't familiar with before, and I'm not an expert in it. It's called a CHADE analysis. Maybe some of you have heard of it, chi-square automatic interaction detection. And it's a non-parametric method aimed at identifying how well a continuous or categorical independent variable predicts the desired outcome. our outcomes were the need for a second Chiari operation or Chiari directed operation, which would include a repeat posterior fossa decompression, placement of a fourth ventricle stent, a cranioscervical fusion, or an odontoid resection. So that was the reason for those were our outcome, our primary outcomes. And we looked at the preoperative list of signs and symptoms that the patient had and a number of radiological variables that we discussed earlier in the talk. And it turns out that the variable that predicts the need for a second operation, the number one is the degree of foramen magnum crowding. That if the posterior fossa and the cervicomedullary CSF spaces were obliterated, there was a significantly higher chance of needing a secondary operation. And this, in my mind, this falls into the category of all this hydrodynamic discussion that we've had today in trying to understand the impact that this has. The next most powerful, if you took those patients who had obliterated CSF spaces, the next most powerful predictor of redo operation was the presence of a syrinx. Most of those patients either went a placement of a fourth ventricle stent or a syrinx shunt. And if you had a syrinx, the next most powerful predictor of repeat operation was, in this case, the PVC2 distance or the extent of ventral brainstem decompression. And these are the patients, these are the complex Chiari patients. And it's a smaller number of patients, obviously, here. So if you had greater than 8.2 millimeters PVC2 distance, you can see a total of 21 patients underwent cranioscervical fusion in this complex group of patients from 272 starters. So when we interpreted these results, we felt that this chain analysis identifies 4 clinical radiographic phenotypes at risk for Chiari-related reoperation. And the first is just the classic Chiari operation, and the chance of needing a reoperation is very, very low. If you had tonsil herniation, if you had crowding or open CSF spaces but not obliteration, the chance of reoperation is very low, probably less than 2%, usually one and done type of surgeries. For obliterated CSF spaces, that's the next sort of clinical radiographic phenotype that this identifies. Obliterated CSF spaces in syringomyelia is the next group. And then the last group is the obliterated CSF spaces, syrinx, and ventral brainstem compression. And this is the complex Chiari population that we've been discussing. So surgical adjuncts and techniques, what do you do with these patients? So a lot of these patients, if you had severe basilar invagination, you can reduce that at the time of surgery. You can also use preoperative halogravity traction. This is an example in a patient with osteogenesis imperfecta, but it's a good example of showing how powerful this technique is and how much reduction you can get. So here's our patient in the halogravity traction, which is very, very effective, and then ultimately his ultimate outcome, and you can see the position of the odontoid after this technique. And this is not an old, this is not in 2020. So for patients who do require fusion, this is what I do in my hands. If they need an occipital C2 fixation, I don't go lower than C2. I place C2 PAR screws bilaterally. I use a rod plate construct. Most of these patients need odontoid reduction. In just a minute, we're going to talk about how that's done exactly. I use rib grafts that span from the occiput down to the posterior arch of C2. This has been shown in a combined orthopedic neurosurgical publication to have higher rates of cranioscervical fusion compared to other techniques. I use recombinant human BMP at the contact points at the top of the rib and the bottom of the rib. I put the gel foam pledgets there. I put a screw through the rib into the occiput to create pressure on it. And that aids in fusion, I think, just with the stress on the bone. And Wolff's law, you get higher rates of fusion. and I use a cable around the rib and around the rod to compress the rib to put stress on it. And there's no need to fixate C1. So one thing that hasn't been talked too much about is how do you do an intraoperative odontoid reduction? And many times you can get up to a half a centimeter, a centimeter of improvement. This is my stepwise way of doing it. You insert the C2 par screws, you cut and bend the occipital cervical rod plate that we just talked about. You place the occipital screws into the plate portion up above. The rod portion hangs down below and is loosely held into that C2 tulip with the lock nuts loose. So the top is tight, the bottom is loose. I break scrub, I go to the head of the table, and then I put my, I do a manual reduction with, the first movement is just axial distraction, and the second movement is extension. What that does is forces the rods ventrally, and that pushes the C2 body, ergo the odontoid ventrally away from the brainstem. And when you're happy with that, you lock the C2 screws in, get an O-arm spin to confirm your reduction and see how that looks. Other issues include using the postoperative cervical collar. We have a great orthotist at our place, and he makes nice collars that are comfortable for the kids. And then this is my imaging protocol for documenting the fusion. I get an x-ray. We could go all day about this topic in and of itself. I get an x-ray a month. In 2 months, the 3-month visit I skip. At 4 months, I get a cervical CT scan. And I think that has a high yield of capturing the successful fusion with the lowest risk of CT radiation. For odontoid resections, we published a paper in 2021 going over this. I'm not going to spend too much time. We use this protocolized approach with our ENT colleagues. It's an endoscopic transnasal, transoral odontoid resection, and it's become very, very straightforward for us. And basically, it amounts to on the impact on the patient of just having an adenoidectomy, and the patients are discharged shortly after surgery. So here's a few case examples I'll go through. So here's an example of this hydrodynamic issue. A 14-year-old girl with severe Valsalva headaches, complete obliteration at the craniocervical junction, the CSF spaces, a little bit of craniocervical kyphosis. Here's the list of potential procedures. A bony decompression, you can do a duroplasty with tonsillar coagulation or tonsillar resection. For her, we decided to do a tonsillar resection, and here's her post-operative imaging on the right-hand side, and she had nice improvement symptomatically. Here's a 10-year-old boy with syringomyelia. These are pictures that we all see all the time. 28-degree scoliosis. Again, the same treatment algorithm, but I think the literature is showing that some sort of a duroplasty technique with or without manipulation of the tonsils is superior to just bony decompression. If the syrinx is still there after 6 to 12 months, re-exploration of the decompression or placement of a stent is a reasonable way to do it. And again, this is not a new concept. This is published by Dr. Scott previously, showing what the stent placement results in. So here's a type of patient which is fairly common. So here's a 2-year-old girl with severe oropharyngeal apraxia. She's just got straightforward brainstem compression, neural compression. And so you're going to address it accordingly. Again, some people would do a bony decompression with or without opening the dura. With this type of patient, I think being relatively aggressive in doing a tonsillar resection is probably, in my hands, the best way of handling that patient. This is a patient who came to me with severe bulbomyelopathy and axis assimilation, retroflexed odontoid. This would be the classic, complex Chiari malformation. It's clival cervical angle 110, CC2 SVA of 12 millimeters. This patient was in trouble. So you're going to handle this in a staged fashion. This patient needs Chiari decompression. He needs his brainstem decompressed, and he needs to be fixated over time. He needs a fusion. So we performed the suboccipital decompression and duroplasty with tonsillar resection. We did an in situ OC2 fusion. There's no way you can reduce the odontoid because C1 is fixed to the clivus and you can't push it forward. So you have to do in situ fusion. And then for the residual odontoid compression, we did our endoscopic transnasal, transoral odontoid resection. Here's another patient with Valsalva headaches, came in severe Chiari, severe craniocervical kyphosis. And we all see these patients over time. And again, you can do the duroplasty with tonsillar coagulation. That's what I did up front. So this was back in 2018, over 7 years ago. He came back about 4 months after surgery. And I have to take, I'll be honest with you, I have to take a step back because my thinking has evolved. He came back with severe headaches and neck pain. And it was hard to determine whether this was a biomechanical problem or whether it was just a CSF flow problem or hydrodynamic problem that was driving his symptoms. I put him into a hard cervical collar, and he had significant improvement of his symptoms. So we decided to do a suboccipital decompression duroplasty. I did a tonsillar resection on this patient secondarily, and I think we all could agree that there are patients that come in with severe crowding. They can be very, very difficult to manage with just the standard decompression techniques, and they can come back with recurrent or continuing symptoms. And then I performed a fusion with odontoid reduction on this patient, and this is the overall result. So in summary, I'll just give you a brief overview of my approach that's evolved over time with 33 years of practice. Obviously, this Chiari malformation, rhomboencephalopathy, whatever we want to call it, it's a spectrum of disease and it's multifactorial. It's very complex, and that's why we're so interested in it, and that's why we love it so much. Identifying the primary problem, what you're trying to fix. Is it a hydrodynamic problem, a compression problem, or a biomechanical problem? Really clarifies your thinking. Patients who fail to respond to simple decompression often have complex craniocervical abnormalities or intradural pathology. Some of those patients have syrinxes or ventral compression. I've done a lot of intradural work that not many people talk about the contribution, for example, of the tonsillar branches of pica that can come up either unilaterally or bilaterally and form obstruction to CSF flow at the foramen of Magendie and the obex, and what role those things happen, or what role those things have. And so sometimes there's intradural pathology that's more complex that needs to be addressed. That's my point. And certain risk factors allow early identification and improved management of complex patients, including this concept of the obliteration of the space and our craniocervical measurements. So what does the future hold with research? We need registries. We need this severity score. It would be very, very helpful. Better understanding of the craniocervical bony morphology and function, and the understanding of ligamentous hypermobility and what that contributes. Advanced CSF flow modeling. I know Dr. Limbrick and others have talked about that. Cerebellar resting state networks. Educating PCPs about Chiari or rhomboencephalopathy and its effects. And what about AI? I think people talked about what happens 20 years from now or 10 years from now if we had this conversation in the future, this conference, and it's all going to be dominated by AI and machine learning. And I think that creating these classification schemes in this organizational framework is going to be very helpful. So if it becomes a supervised learning approach with machine learning, with these classifications building the framework around which the AI and the machine learning would function. So I want to thank everybody for your attention, and I'm happy to answer any questions that you have. Thank you.
Thank you very much, Professor Brockmeyer, for that excellent lecture. Giving us the, we have certainly in my practice, when I did Chiari, it was once or twice we get these complex ones. Even the simple ones are difficult, but it's really good to hear from you how you manage these complex cases. And as you said, AI is going for something as complex and multifactorial. Probably AI is going to be a very powerful tool. I think that's for the craniocervical junction community to see how to bring that on. Before I move to our distinguished faculty to ask you questions, just to remind, at the end of the housekeeping, at the end of the next talk, next lecture from Dr. Rizk, I'll put the link for the feedback form. It's a very simple feedback form. It's an open paragraph for you to give your feedback. There's no mind-numbing radio button to click. And then I will send you a certificate for attendance, and as well as a database for Chiari that will run on Mac or Windows. You have to just download the free LibreOffice, and also a software for pediatric calculations, which will run on Mac or Windows, and also the web link for the Chiari, Chicago Chiari outcome scale. So it's a real honor to have two more distinguished panelists. First of all, Dr. Sushil Patakar. He's from Pune, very experienced spinal surgeon, and particular interest in craniocervical junction, spinal neurosurgeon with particular interest in craniocervical junction. And we have got Dr. Sama Elbabaa, whom we all know from the pediatric side. Dr. Sushil Patakar, your comments and questions to Dr. Brockmeyer, please. Thank you, sir.
Yeah, Professor Douglas was a fantastic talk and very, very informative. I have two questions for him. Number one is how much importance do you give to the occipito-atlantal angle between both the occipito-atlantal joints? Because more than 130 means there's a hypoplasia of the condyles, and this patient is going to go into instability after surgery. And second, the technique which you showed of putting the rib grafts was somewhat similar to that which has been pushed by Dr. Sarat Chandra, where he talks about DECR, that is distraction, extension, compression, reduction. And to correct retroverted odontoid, it is important to push something into the atlantoaxial joint, and the fusion has to occur across the atlantoaxial joint. What are your comments on both these questions?
Yeah, I'll take the second one first. So, the DECRA procedure, I think that's what you're describing. And I think that's for patients specifically with atlantoaxial subluxation. I think that's very effective. I know Dr. Goel was on the talk. I don't know if he's still on the talk. And he has a large experience with that technique. I don't use that specifically. I think that you asked about the clival cervical angle. I'm not treating the number. And I don't think there's one number. There's patients that are at higher risk, and you're going to pay attention to those patients. But it's not like, oh, you come in with 110 CXA, and we're going to fix you. We're going to put you at 130 or 135. That's not what the goal is, I don't think. In a lot of patients with severe kyphosis, you can do a posterior decompression. They do just fine. And I think that's the integrity of the capsular ligaments, at OC1 and C1, C2. If they're intact, most kids will not become unstable over time. But I think that, again, repeated surgeries over time can weaken that tension band in the back. And I think just the weight of the head over time, you have that glacial instability and further kyphosis. We've all seen it. And I think that we need to treat those patients accordingly. It's not super common, but when you have a patient come in post-operatively who's really disabled with headaches, neck pain, can't go to school, can't do anything. And that's really it's a difficult decision, but it's definitely the right management, I think, over time.
So am I right that you don't advocate a primary fusion procedure? You would first do the decompression and then decide with the new, if there is any problem, then decide for a fusion. You wouldn't go for a fusion straight away in any patient.
Yeah, well, it depends. So it's like that last patient I saw came in with severe brainstem symptoms, and he needs everything, right? I mean, he's going to need a posterior decompression, fusion, and odontoid resection to decompress his brainstem and manage him over the long haul. So sometimes there's a multi-stage procedure that has to happen for certain patients. Those patients are uncommon. But the typical patient who comes in with like a CXA of 115 and they're tight, I think the consensus, and they have Valsalva-induced headaches, again, doing a standard decompression, seeing what happens over time. If they fall apart over time and they develop kyphosis and pain, then going back to do a secondary fusion is a pretty rational way to manage that. Like I use fusion as a last resort. They have to prove they need the fusion. Let's put it that way.
Thank you. Thank you.
Thank you very much, Dr. Patakar. Was the first question answered, Dr. Patakar? Sorry,
No, I don't know. The question was the clivo, the occipito-atlantal angle, and like he said that these figures are not important, and he would rather go with the clinical situation rather than the figures in the what kind of clivo-axial angle or atlanto-axial angle.
That's great. Thank you. So both answered. Dr. Samar Elbabaa. Dr. Samar Elbabaa is from Orlando in Florida, from Arnold Palmer Children's Hospital. He's the head of the department there, as well as the chief physician, Dr. Elbabaa. Your questions and comments, Dr. Brockmeyer. Thank you.
Thank you, Narayan, and thanks to all the faculty and colleagues attending today. As always, excellent lecture by Professor Brockmeyer, very enlightening, and I learned so much. One of the main things I learned from your talk is your focus on the clinical symptoms and how patients, radiographically, they may look good, and then they come back and they have symptoms. You put them in a collar, and now after the collar, you started thinking in a different direction towards a successful treatment plan. How about patients who come, like let's say with a Chiari type 1, a syrinx? Very soon, we're not going to be saying Chiari type 1 with this thromboencephalopathy. Actually, probably it's the future where we're heading in understanding this disease. But let's say a patient comes with a Chiari type 1 and a syrinx, and we do decompression like most of us do. Syrinx gets better, clinically better. A year later, they come to their office, they look amazing, but now the syrinx is slowly coming back. And those are the kids, especially kids under the age of 10 who I struggle with. And I would like to learn from you and listen to your algorithm. How do you differentiate between clinical and radiographic progression, and do they need to match to change the treatment plan or not? Thank you.
Yeah, Samar, thank you. So that's a great question and something that I've struggled with. Again, the rhomboencephalopathy concept, I haven't talked a lot about it over the years because it's new, and I wanted to introduce it to this sort of distinguished international group today, just to sort of bring it to people's attention. Those delayed recurrent syrinx patients, what my mind immediately goes to is there scarring at the fourth ventricular outflow? Okay, so and there's a variety of reasons for that, right? The amount of blood that was in if you did an intradural procedure, how much blood was in the intradural space, how much tonsillar manipulation did you do? Was there a web? Was there a blockage from the tonsillar branches of pica? Those are just four things that come to mind. And if it's clearly getting worse over time, and I'm sure that if left untreated, it's going to continue, I'll re-explore it. And if there's evidence of scarring and I can open it up and I can confidently say the chance of that rescarring is very low, there's not a lot of scar, I'll leave it alone. I won't put anything in. If there's a lot of scarring that you have to take down, I'll definitely put a stent into those patients. And I think that most people are going in that direction. A lot of people are, and that works like crazy. And there's a building experience with that. And if you have that outflow obstruction and it's scarred, that's just what's going to happen.
Thank you, sir.
Thank you very much, Doctor. Thank you very much, Dr. Elbabaa. Dr. Patakar, do you have any more questions?
One more question for Professor and everybody. When you do a posterior fossa decompression and open the dura, there are some who advocate not to open the dura and just leave the arachnoid, and some would say you must open the dura and the arachnoid and open the fourth ventricle. What is your opinion about making an attempt every time to open the fourth ventricle and the foramen magendae?
My reply to that is that if somebody has a hydrodynamic problem, it's my responsibility to make sure that the outflow obstruction is addressed. So I will explore the fourth ventricle. If the obex is low lying and the tonsils are low lying, and this is my thinking has evolved over time. And I hopefully it won't be too controversial here, but I've gone more toward tonsillar resection more than tonsillar coagulation because that creates a lot of inflammation. And whereas a subpial resection has less inflammation, I think less, I mean, you're removing tissue, but ultimately less external signs of trauma and less chance of having scarring that's going to cause more trouble down the road. So my way, I've been going more toward tonsillar resection over time and making sure that the CSF flow pathway is open. That's just been my preference. And I've had a lot of success with that over the years.
Thank you. Thank you.
Thank you, Dr. Bhatkar. Dr. Samer Elbabaa, any additional questions?
I'm interested in the comment from George earlier after his excellent talk, saying that he does not routinely perform neurophysiological monitoring for Chiari decompressions, which is obviously we all have different practices, different medical legal environments. Question to the distinguished faculty, do we have enough scientific data now in the literature where one day we can come out with maybe guidelines or recommendations? This is a Chiari we should monitor, and this one we should not. A question to both all professors, all distinguished faculty.
Dr. Brockmeyer, do you want to first go?
Sure, I'll tackle that. I had a patient probably 10 years ago with severe kyphosis and really, really tight. I put her in the usual position and she woke up with a stroke, pica stroke. And I think that the odontoid was right at the vertebral basilar junction there. And that was enough for me. And that was a horrible experience. And so everybody with a tight posterior fossa or a craniocervical kyphosis, I'll definitely monitor those patients. Somebody with a routine Chiari that's wide open, I might not. So mine is situation specific, but I think if you're tight and kyphotic, you should be monitored.
Thank you. How about George? How do you decide to monitor or not?
Some great question. I think in most of cases, I don't routinely monitor, but I agree with Doug. I mean, I think it's a case by case, right? As an example, why do I don't monitor my routine Chiaris, but I monitor all my achondroplasia children, babies that need a decompression. And it's for that reason. I think we probably do need guidelines, but right now it's individual based, and it's ones, I would say the complex Chiaris are the ones I would consider it at this time.
How about a simple Chiari with a C-rings?
No.
Okay, thank you.
So
Elias?
I'm happy to share with you a couple of articles regarding this topic, but there's really no, in straightforward Chiaris, there's really no cost benefits or any cases in the medical legal literature that's referred neuromonitoring as malpractice or substandard in a treatment of straightforward Chiari. So if these are cases that are selected based on the surgeon's judgment, that's fine. But like, there's a couple of articles out right now that don't show an added benefit of doing neuromonitoring in straightforward Chiari malformations.
And Elias, I agree with you 100%. I'll put those 2 articles in the chat for everybody.
Dr. Patakar, with your extensive practice, you must have seen enough cases or heard enough cases with patient post-operatively having problem after.
I do neuromonitoring the moment, like what Douglas said, that if there is a retroverted odontoid and severe compression, or I have established instability preoperatively, I would definitely go in for doing neuromonitoring during surgery. Sometimes in instability, just giving a prone position can change the potentials. So it is better to be safe than to be sorry, I would feel.
Thank you.
When I was a resident in south of England, in somewhere further up north, once again, the same as Dr. Brockmeyer said, I don't know the exact details of the case, but post-operatively had a stroke. So as I said, you are distinguished and incredibly experienced, but I'm always a bit anxious putting patients with Chiari in a good tuck position. Ideally, I would also like to have neuromonitoring to be safe. And sorry if I had the facility. Dr. Brockmeyer.
I just want to make one comment. So the monitoring's not perfect though, right? So once monitoring changed, the event has probably already happened.
100%.
You can undo the position and treat it and all sort. But the bad problem may have already happened, but there's always a delay in detecting it. So it's not perfect for sure.
And I've had cases where neuromonitoring was added on as a separate charge to the patients, irrespective of their insurance coverage. And the families get like a bill separate from the neuromonitoring company, and they phone in and say, not in, all the cases, but they're starting to charge separately for services that insurances are not covering. I don't know if any of the faculty here has had that experience.
I think yes, it depends if the neuromonitoring team is employed by the hospital or a contracted company.
Yeah.
Thank you. In terms of Dr. Jallo, do you have questions for Dr. Brockmeyer?
No, hey, Doug, I mean, great talk. When you stage your, posterior decompression and then your anterior odontectomy, what's the time that you typically wait before you perform the operations?
Yeah, that's a great question. So sometimes patients would come and they clearly needed everything. So tried it every way possible, where you do it all in one day, do it from the front, do it from the back, front. So basically what I settled on over the years was to do everything possible from the back, with or without the reduction. And then I'd probably wait, and then I'd get imaging afterwards, and then wait 2 or 3 days. And then I'd go from the front and do the odontoid, which is less morbid than people believe. And those patients recover within a couple of days with the endoscopic procedure. So I would stage that usually with 2 or 3 days in between.
Thank you.
Dr. Brockmeyer, if I missed, if you had made the point, if I missed, I apologize. When you are running the webinar, you have to do a few things. So in terms of patients with Chiari, do you routinely do flexion extension x-rays on them to look at the stability or not?
I do not. I do not.
Thanks.
I think the incidence of true instability in the pediatric population is very low.
Thanks. Dr. Patakar, I saw the guidelines, the WFNS published on that,
Yes.
and also said the same thing. Is that right?
Yes, you're right. But I think, you see, we do not have so much insurance and financial problems back here in India, and we can get the investigations done very easily. I also like to do when I do the MRI, I do the dynamic MRI. So that gives me an indication, and when the same MRI is being done, a dynamic MRI solves my problem, and I come to know if there's an instability there and then. I don't have to do a separate investigation.
Could you explain what a dynamic MRI, please, Dr. Patakar?
We tell the radiologist, and they have a flexion extension while doing the MRI itself.
Okay, that's great. Thanks. Thank you. Dr. Elias Risk, do you have questions for Dr. Brockmeyer? While he's here, we better ask as many questions as him.
No, that was superb and masterful as usually in 33 years of experience. I'm sure lots of families are thankful for your dedication, hard work, and also we're all thankful for all the work that you've done in pediatric neurosurgery, especially in Chiari.
Elias, thank you very much for those comments. I appreciate that.
Dr. Brockmeyer, I've got two general questions. One is from the chat box and one is from me. I think I'll go to the mind first. In terms of we through this conference symposium, we have said that Chiari is kind of multifactorial, important to work out, what kind of, as you said, whether it's hydrodynamic stability, what's the cause. And the complications that I have, the problems I have seen is that people usually, have a knee jerk that they see a Chiari, they go for a foramen magnum decompression. And in terms of working up, how long and how extensive should the workout be? I know it depends on how complex the case looks, but even for a standard Chiari 1 malformation, we talked earlier about craniosynostosis, we talked about genetics, we talked about instability, we talked about connective tissue disease, we talked about tethered cord, and how much thorough workup. Usually the neurologists are the ones who you expect to do thorough workup, but neurosurgeons are more keen on the operation. What's your thoughts on that? Thanks.
Yeah, great question. I think in the pediatric population, it's more straightforward. And I would do a complete craniospinal MRI as a baseline just to make sure that there's no other pathology that's driving anything. And after that, and if I'm comfortable with my decision making and how the patient presents, I'll just move forward. With adults, I'm learning it's a lot more complex. I've been doing this for probably 5 or 10 years. And trying to it's very, very, very challenging, IIH and hypermobile patients, et cetera. So there's a lot more hand wringing and there's a lot more collaboration with headache neurology and dysautonomia and, all these things. So I'm not really answering your question that very well, but it just is suffice to say in the adult population, it's a lot more complex.
That's great. Thank you very much. The final question is from one of the participants is that have you come across a family where the patient is asymptomatic, but it's Chiari, patients have gone through the internet and they are insisting that they want an operation, otherwise they are they have got so much anxiety. How would you deal with that? Thanks.
There's a lot of experience in this symposium. Maybe I would have a tendency just to say wait and see. You could ultimately say somebody's going to do that operation somewhere, so why not me? But I tend to pass on those patients if they're driving the decision, if they're asymptomatic. I don't treat the MRIs, and even if the anxiety level is high.
When you say pass on the patients, what does that mean, Dr. Brockmeyer?
I just say, hey, look, I can't help you. I can refer you to other people. I think that would be reasonable, but I'm not super aggressive in that scenario.
That's brilliant. Thank you so much, Dr. Brockmeyer, for that masterclass lecture, and we are all very grateful for your service to this field, and not only for our lecture, but to this field. Thank you very much, sir.
Thank you, Naren.